Yeah, good morning everyone. After the basics and normal awake EEG and activation procedure, I'll be covering the normal sleep EEG and its variants. No outpatient EEG can be considered to be complete unless you have a good sleep EEG record. For obvious reasons, sir has already told, sleep is the most potent activation procedures amongst the list of whole. In fact, we do hyperventilation, photic, everything, and majority of the time we see that sleep is the only phase where you have activation of the abnormal epileptiform discharges, and which were absent because outpatient EEG was done 4 times, but a good sleep EEG record was not done. And in that also, a sleep record after partial sleep deprivation is the best, and because it has a propensity to bring out those epileptiform discharges very well, especially in focal epilepsies, especially in benign Rolandic or benign epilepsies, BRE sort of scenarios. This is a recent paper which has given the minimum recording standards published by International Federation of Clinical Neurophysiology and ILE, and they say the sleep induction, basically partial sleep deprivation in adults and children above 12 years of age is what is recommended. And in children less than 12 years, wherever it is not feasible, one can use either melatonin, or if melatonin is not available, chloral hydrate, 30 to 60 minutes before EEG recording. And usually sleep deprivation, we tell them to go to sleep 2 hours later and wake up 2 hours early. And what is recommended is something like 12 o'clock midnight, going to sleep and waking up by around 4 or 5 a.m. and then not going to sleep before the EEG. Coming to the EEG lab in morning hours after breakfast, because that is a time with sleep deprivation, and after breakfast or after meals, you have highest propensity to go to attain a natural sleep, and thereby increasing the yield of EEG. And in specific scenarios, you can individualize, like I told, early morning again, the myoclonic jerks, when it can be very prominent. So once you finish the EEG record, sometimes you should continue it for 5 to 10 minutes, especially because you may get those abnormal epileptiform discharges, you may get some myoclonic jerks. In LGS sort of scenarios, just after waking up, they have this tonic seizures. So modify your EEG accordingly, and don't stop at the EEG. Once the sleep record is over, wake them up and wait for 5 to 10 minutes in the scenario where you feel that there can be increased yield. Now, outpatient EEG, we usually get the NREM phase 1, 2, and 3, N1, N2, N3. N1 is drowsiness, N2 is light sleep, and N3 is deep sleep. And the EEG signatures for each are different. Drowsiness is from wakefulness, where there is a good background alpha, to the appearance of vertex waves. Stage 2 is light sleep, which is characterized by spindles, vertex, and K complex. And this is this phase where you have the maximum chances of getting abnormal epileptiform discharges. N3 is the deep sleep, where the majority of the background is by high amplitude delta waves, which is more than 20% of the record, and you rarely get these spindles and vertex waves. REM sleep, usually you don't get, where the background pattern is desynchronization with faster frequencies and rapid eye movements. We'll cover each one of them. And there are some arousal responses like which can be mimicking abnormal, so you should be aware of what are normal arousal responses. What are the key features which tell, okay, the person is becoming drowsy? When you look page by page, you get a good background alpha. What happens is, after a few seconds, the alpha will stop dropping off. It will be replaced by a slower frequency rhythm, and posteriorly a slower dominant rhythm. The amplitude will be attenuated. There will be reduction in eye blinks. There will be reduction in myogenic artifacts. Frontally, there may be a little faster rhythm, or frontally faster beta rhythm may be seen, and there can be what we call a slow roving side-to-side pendular eye movements. We'll see each one of them. This is a good normal background alpha spindling. Both sides it is seen, posteriorly dominant rhythm. Some myogenic artifacts are seen. The next page, what has happened? The alpha is replaced by a slower low amplitude rhythm, what we classically call it as alpha dropout. In between it may happen. The patient can become a minute later little alert, then again become drowsy. So back and forth they will move till the time they go into stage 1 to then stage 2 sleep. So here it is replaced by a slower frequency rhythm. Again, the next page, what happened? Initial 3 seconds there was a dropout. He become little alert. and so there was again appearance of the background alpha. Again, the next page, he has become drowsy. Now we see the whole of the page. We don't see much of the eye blinks, no myogenic artifact, and the alpha is not seen. It is replaced by a low amplitude slow rhythm posteriorly. So classical alpha dropout. And yes, this is continuous. In between, you can see brief alpha frequency rhythms. It goes on. Again, one more thing, what we see is what we call as pendular roving eye movements. What is like for the tongue tip and tongue base, the base being negative, the cornea is electropositive and retina is electronegative. So during the drowsiness, there are slow physiological movements of eyes side to side, and because there is a polarity difference between this cornea and retina, due to this eye movements, the baseline will move apart. It will be a slow movements of the baseline, and whichever side the eye is moving, that side the temporal electrode will become positive. So FP1, F7 is positive, so it will move up, the baseline will move up. F7 T1 or F7 T3, it will be F7 is negative, so it will be going down. So we say the window is opening up. Whichever side the eye is moving, the window is opening up. Contralaterally, because both eyes will move synchronously, the retina will be close by. Exactly opposite will be happening, and the baseline will come close by. So we say whichever side the eye is moving, the window opens up, or you can fit the eyeball over there. And these are the slow roving pendular eye movements which are seen in drowsiness. And this continues till the time there is appearance of the first vertex wave over here, and then they move into stage 2. Apart from this, there can be few variants which can be seen, which can be misinterpreted as abnormal if you are not aware of it. The classical one is the midline theta rhythm of drowsiness, or Siganek rhythm. It is 4 to 7 hertz rhythm which is in the parasagittal chain midline and sometimes to parasagittal. FZ, CZ it is seen. It is sinusoidal, smooth, mu shape or spiky. Sometimes it can look little spiky. And this is a classical midline theta rhythm of drowsiness. Again, the same patient, the next page also. So it will be persistent, and it is a classical sinusoidal midline theta rhythm of drowsiness. In fact, something which is happening in the parasagittal chain in sleep, the dictum is it has to be physiological. So most of the time it is one of the physiological patterns. Again, in drowsiness, especially in young children, you can get this sort of high amplitude, like sir had shown in hyperventilation induced high amplitude slowing. In drowsiness also, in young children, there can be a very, very high amplitude, bilaterally synchronous 3 to 5 hertz, 3 to 4 hertz or 3 to 5 hertz rhythm. And if you look at some, if you reduce the amplitude, you reduce the gain of it, there can be some superimposed sharp waves seen on it. But then these are not abnormal. These are classical drowsy buzz or hypnagogic hypersynchrony. The same page, if we see in this patient, yes, they are very, very classical sinusoidal waveforms and symmetric synchronous. Sometimes what can happen is, if the background superimposes, if you try to tease it too much, and to the inexperienced it may look like there are some sharp waves which are seen in middle of this, and it may be misinterpreted as generalized spike and wave or generalized sharp and slow wave. So they should not be taken as abnormal. See, the beginning of it is sinusoidal, so any amount of sharp wave which is seen in this, you should just take it that they are not epileptiform. And anyways, they are the part of the background unless you get it in wakefulness or deeper sleep. Because what has happened is, on the top of this sinusoidal slow waves, the background wave has appeared, and it made it appear as a notch, acute notch over there, looking like spike and slow wave. Now from stage 1, we move to stage 2 sleep. Stage 2 sleeps is characterized by posts, vertex waves, sleep spindle, and K complexes. These are the classical posts, what we see in the, it is like an end of chain phenomenon we are seeing in P3O1, P4O2. The polarity is positive because P3O1, it is going up. So either P3 is negative or O1 is positive. If the source would have been P3, we would have seen a phase reversal at P3 which is not seen. So these are the positive occipital sharp transients and which are seen in drowsiness or light sleep. Sometimes they can come up singly or they can come in short runs, and it is similar to the lambda waves what sir has shown in the children when they are scanning or they are looking on some objects. In the average referential montage, the same page, we can see, appreciate the polarity. See, they are they are positive. They are positive, O1 and O2 compared to average, it is going down, so they are positive. And again, the morphology, the location, the state of the patient, these are the classical posts. Don't misinterpret them for abnormal occipital spike. Use your polarity principles. Even if it is the end of chain, the occipital spikes will look like what we are seeing in average. They will look like in longitudinal bipolar because O1 will be negative. Here O1 is positive. Again, I told sometimes they can run, they appear in run, usually majority of the time. If you see those paper EEGs somebody is bringing to your chamber, and on that single page if you see one or two alone, and if they are really sharp, sometimes they can be sharpish like this over here, so they can be really misinterpreted. But unless you pay attention for a second, look for your polarity principles, look for the state of patients, you know, okay, the morphology, the location, everything, it fits in with posts. The posts are not that sinusoidal, they are appearing like little sharp and sharpish wave with a rapid upstroke and slow downstroke. Usually, again, they are seen in females and young adults. Again, one same page of the posts seen in average referential montage, it looks very sharp, but then we know with polarity principles these are positives, so these are not occipital spikes. Stage 2 sleep, again characterized by sharp vertex waves. Vertex waves is one of the common transient which is physiological, which is very commonly misinterpreted as abnormal epileptiform or pathological. These are usually biphasic or triphasic waveforms which are phase reversing across the midline CZ, C3, C4. Some of them, it can happen, few of them can phase reverse across P3, P4 also. And they are usually frontocentral and with a field to a parietal region, symmetric, synchronous. They can be variable in amplitude, sometimes very high amplitude in children, very sharp contured, and they can occur in runs also. So these are the classical vertex waves. What can happen is sometimes in children, they are usually, I told it is symmetric synchronous, but when they are going to sleep, usually for first few of them, they can appear to you as little asymmetric. Especially over here, we can see this first one, if we see, it was on the left, second one on the right, and then subsequently they are symmetric synchronous. So even if some asymmetry is there in one of them or few of them, then that is not abnormal unless you see consistently they are seen on a particular side and they are absent on the other side. And again, it can happen if it is a single page where we are seeing one of them and it is towards the end of the page, and this can be misinterpreted as abnormal unless you see a one page previous or few pages afterwards and you see, okay, you realize these are parasagittal vertex waves only this one transient came on the unilateral side. So that's the reason that you should read EEG not read on the papers, the printouts which you are given to you, but then read on the console, read page by page, teach your technicians so they also don't misinterpret it as abnormal and bring you those papers that telling that, okay, there is a sharp transient over the parasagittal region on left or right side. Sometimes you can have vertex waves can come in really short runs. These are again misinterpreted as an abnormal theta slowing, which are generalized or which are parasagittal. In children's, the vertex waves can really come in short runs lasting for 1 to 2 to 3 seconds also. But look at the morphology, look at the locations, and this is a classical vertex wave which is coming as a short run. Again, the same patient. Once you see, unless you enjoy the EEG reading, it is difficult. Once you enjoy, and for everything which you have read, which you have heard somewhere, and unless that enthusiasm is there, you will not enjoy it. See, these are the short runs, and in a particular patient, when you have these short runs, you see page after page, you will have much more of them, and that will make it very clear, okay, that this is a short runs of vertex wave. Same patient, we can see there is a short run of vertex waves again, which can be really misinterpreted as an abnormal slowing. And 3 seconds later, again, there is a classical vertex wave which is seen over here. Sleep spindles. Sleep spindles are usually 12 to 16, we say around 14 hertz, electronegative with round positive component, giving them a fusiform or comb-like morphology. The location is again the same, parasagittal centroparietal region. They are seen in the midline and again on the midline. Usually, they are seen in the age group of first 2 to 3 months. They can be little asynchronous or asymmetric till 12 to 24 months of age. And in young children, especially, which will be covered, infants, they can be very long duration, lasting for, over here it is lasting for almost 6 seconds, so they can be sometimes very long, lasting for 8 to 10 seconds even. What is K-complex? Basically, a K-complex is nothing but a broad, sharp vertex wave, which is polyphasic, and which is just following it, there is a spindle. So there is a combination of broad, sharp, polyphasic vertex wave with superimposed fast component to the end of it. This is what is classical Clay complex. Here we can see the previous one was very broad, sharp, followed by the sleep spindle, making it a broad, sharp K complex. Sometimes the K complex can be sharp, and this is again the sharp looking K complex, which is followed by the faster beta activity, the sleep spindles which are overlapping on it, and this is a classical sharp K complex. Sometimes it can happen, the K complexes, it may not be always that there is a broad sharp vertex wave and then there is a sleep spindle. Sometimes it can happen in middle of that sleep spindle also there can be overlapping broad sharp vertex waves can be seen. So there can be K complexes which can be where the broad sharp wave vertex waves, although classical definition is a broad sharp vertex wave which is polyphasic, followed by the faster rhythm. But then when you see page by page, you will realize many of the times it can happen, the broad sharp vertex waves can be superimposed in the middle of it, towards the end of it. Again, these are absolutely normal physiological vertex waves and K complexes. This is a very interesting page. On the same page, you are seeing all the patterns. There is a good K complex over here, very good, sharp K complex. Then there are the sleep spindles over here. There are the vertex waves over here, and anything else you can see. So if you look carefully, see there you can see there are the posts over here. So this is just the patient is becoming from stage 1 to stage 2, and on a single page you can see everything what is seen in stage 1 and stage 2 sleep. So same page you can see everything. One more pattern, just what is called as mitten wave. What is happening is these broad sharp vertex waves, and if the background is just superimposing at the beginning of that broad sharp vertex waves, it can give a notched appearance looking like a mitten, thumb and the hand. Especially if you look it in average referential montage and in young children's, this is a classical mitten wave. And this is again a variant of K complex, and location is again the same. Sometimes it can be seen more anteriorly over the frontal rather than central regions. Again the same patient, few pages later, one more, the classical mitten wave or mitten pattern, which is again the variant of the same. It will be covered again, the cone waves, usually they are the normal variants of delta waves seen in NREM sleep, which are triangular morphology, or monophasic or diphasic, over the occiput, usually seen in kids between 6 months to 3 years of age, and this is the classical cone wave. The morphology looks like cone, biphasic or triphasic waves. Now the key features of stage 3 sleeps are the classical delta slowing, and the vertex waves and the spindles will become infrequent. Again in stage 3, again our spikes also might be, epileptiform discharges also will be less frequent and sometimes can be fragmented also. This is a classical slow wave sleep which is characterized by a generalized high amplitude polymorphic delta rhythm, and you can see sometimes some vertex waves in between, some sleep spindles in between. And usually in young children, when we give them either melatonin or pedicloryl and chloral hydrate and they go to sleep, you get this sort of generalized slow wave sleep predominantly. Again, example of slow wave sleep which is seen. Like sleep, there are some arousal patterns also which are very characteristics and which you should know. And once you have got a 20-25 minutes, 20-minute sleep record, you wake them up and see for arousal response, see for appearance of abnormal discharges also. So here the sleep spindle is seen, the patient's name is called. Usually what is pattern is there is a theta sort of slowing and it settles down and then the background alpha comes. That is a first classical pattern. Sometimes it can be there when they are going to sleep or when they don't achieve a deep sleep, there can be internal arousals also, what sir has shown, or paradoxical alphas also in early stages you see. And just when they are waking up also, it can happen that they just don't get the theta, and then especially if they are in the light sleep, it can just directly go back to the background alpha rhythm. What we saw in drowsiness or going to sleep can happen during arousal also. That was hypnagogic hypersynchrony, and this is hypnopompic hypersynchrony. Again, similar high amplitude, generalized polymorphic delta waves, and if their background is superimposed, they can look like sharp and slow waves. And these are absolutely normal. These are not pathological. Again, just summarizing what we see in drowsiness is attenuation of posterior dominant rhythm or the alpha dropout, decreased myogenic artifacts, decreased eye blinks, some pendular roving eye movement, the Zeigarnik rhythm, and in young children can get hypnagogic hypersynchrony. In N2 sleep, we get posts, we get vortex waves, we get K complexes, we get sleep spindles. And in deep sleep, we get predominantly the background is the slow delta activity. What is abnormal? Abnormal sleep is if there is an absence of sleep architecture on the side, on a particular slide, may it be vertex waves, may it be absence of sleep spindles, then that is definitely abnormal and that side is pathological. Or there is a persistent asymmetry, if it is there in vertex waves or sleep spindles, can happen in sites of callosilogenesis sort of phenomenon where you can have persistent asymmetry. Or if there is a discontinuity in background, or the last but not least, why we wish to have a good sleep record is having a presence of epileptiform abnormalities. Just want to say that anything which you see centrally or parasagittally in sleep usually has to be taken that it is mostly a physiological variation, either of this vertex or any sharp transient could be this vertex waves or K complexes, and even if there is a slowing, then this is a physiological slowing, not abnormal unless proven otherwise. Thank you.